So I wanted to welcome our audience to our COVID-19 weekly clinical rounds. As you're aware, today's topic will be critical care, clinical and ethical decision-making. Just wanted to make you aware of a number of other resources that are available to you across the North. When you came in today and you're on this screen, you'll notice there's a button for clinical resources. And if you push that button and go to our Northern Ontario Clinical Resources website, you'll be able to find a number of resources here of potential use to you in your clinical practice. Just wanted to bring everyone's attention to our case status in Northern Ontario. So as of 11 o'clock this morning, we have 75 reported cases from our public health units across the North. You can see that there is an outbreak currently in Porcupine, that's Timmins, Ontario right now, and they have a number of patients in their critical care unit. And again, you can see the number of cases in Sudbury, North Bay, and as we come to the west here, Thunder Bay, and then the rest of Northwest Ontario is 5. The other thing on our website, there will be some, you can have access to some critical care skills and resources, which will be mentioned through the presentation today. There's a link to emerging literature. There's a link to Indigenous resources, maternity, pediatric, and then finally primary care resources. And for those of you who are in a precepting role or a supervising role of learners, we're starting to develop some online resources here that will be of note to you as well. And I'm just going to pause there for a minute and just see whether Dr. Ahmed and Dr. Scott have been able to join us at this point.
I just got in. There we go.
Wonderful. That sounds like Mike Scott.
Yeah, that's correct. Sorry. Thanks.
Wonderful.
And I can see, yes, I can see actually now. Yay.
Great.
Thanks, Mike. So welcome again, and I think we'll get started. So welcome to COVID-19 rounds. Again, please mute your mic, and you may get better reception if you're using the audio line as part of your computer. We've already talked about our case status now in Northern Ontario. Again, this is available on the NOSM Northern Ontario Clinical Resource site. Questions throughout the presentation today, please push them through the chat feature of WebEx, and those questions will be relayed to our presenters and our moderator. If you're on phone and you'd like to send questions, you can use the CPD email address. Just a notification that our planning committee has been developing these rounds using the current information that's available. As everyone is aware, COVID-19 information is changing almost daily. So we encourage you to be continuing to access different sites to get up-to-date information. There's been no sponsorship or no committee members receive funding. I'd like to introduce our presenting team today. Our moderator will be Dr. Sarah Newberry. Sarah is a family physician from Marathon and now the Assistant Dean of Physician Workforce Strategy at NOSM. And Sarah, I'll let you introduce the rest of your team.
Yeah, thanks so much, James. I'll just see if the sound quality is okay.
Good sound quality.
Great. Well, thanks so much for that. It's really a pleasure to be here today to participate in this conversation and to welcome Dr. Mike Scott, who's an intensivist and the critical care lead for Ontario Health North, Zaki Ahmed, who's also an intensivist and the Chief of Staff at Thunder Bay Regional Hospital. And I'm also really pleased that we have Dr. Tien, who is the CEO of Ornge, our provincial air ambulance transfer service. This conversation really has emerged as I think clinicians all across Northern Ontario and in our small communities in particular have begun to grapple with the issues of some of the ethical decisions that we've watched colleagues have to make in places like Italy and New York as the COVID-19 pandemic and in fact crisis has emerged. And many of the questions that we've had from a small community context have been about how do we ensure, in as much as we are able, equitable access to transport resources in the province? How do we understand ventilator capacity and the principles of fairness and equity and how ventilator access might be distributed across the province as the COVID-19 pandemic emerges for us here. And so as chiefs of staff in the northwest corner of the province, we've had an opportunity to have a conversation with Doctors Scott and Ahmed and Tien over the last couple of weeks, and felt that this was a really important opportunity to share this with the wider NOSM community, so that we have across the whole of the North a shared understanding of the ethical framework around triage and capacity for the province of Ontario. Like many of us these days, there are multiple meetings sort of evolving in our day-to-day schedule, and we're really fortunate to have Dr. Tien with us, but only till 1 o'clock. So we thought we would start with him and his conversation about Ornge and Ornge's role in supporting the needs of critical care patients across our region. We won't have time to take questions for him to be responded to today, but please do post your questions for Dr. Tien. We will gather those up and submit them to Ornge, and then responses to those questions can be posted under the critical care resources section of the NOSM website that Dr. Gertson has just spoken to. So with that, I am really pleased to welcome Dr. Tien to this NOSM webinar. Dr. Tien, over to you.
Thanks, Dr. Newberry. So I really appreciate the opportunity to say a few words here. I'm just going to talk a bit about what we've been doing at Ornge to increase our ability to respond to calls in the north. It really breaks down to increasing our HR assets and preserving our human resources assets, and coming up with a surge plan for having to transfer multiple patients. So what we've done with regards to HR resources are that you may not have known this, but prior to COVID, there was a shortage of fixed wing pilots in the north. The commercial airlines were all hiring them. And so obviously now the situation has changed dramatically. So we are actively going back to recruit the fixed wing pilots that we lost during the upswing in the commercial airline industry, and actually have supernumerary positions for fixed wing pilots, which are the primary support to the remote communities in the north. And we've had a lot of traction with this. With regards to paramedics, there's two things that we're doing. One is we're trying to change, or at least temporarily change, the patient care and transport standards under the Ontario Ambulance Act, which you may know requires 2 paramedics in the back of every ambulance to allow a certain level of care. So what we've asked for is a temporary change to the patient care and transport standard to allow 1 critical care paramedic in the back of the aircraft to allow for a critical care level of care. This might sound problematic to you, but if you think about a land ambulance, the idea of that standard was to allow for 2 paramedics in a land ambulance, with 1 driving, 1 in the back of the aircraft. In the case of an aircraft, we have a pilot, and so having 1 critical paramedic is synonymous with what we normally do with land ambulances. Obviously, with very dynamic, very sick patients, it's still very useful to have 2 critical care paramedics. So there will be some oversight into if and when we get the PCTS changed, how we utilize the single paramedic versus dual paramedic configuration. The other thing that you may or may not know is that Ornge operates both a dedicated fleet of advanced care and critical care paramedics, and utilizes various contract carriers to provide support to the north. These are usually in the primary care configuration. We've been modifying the aircraft in the SA carriers, which are slightly larger, to allow for dual ventilator transport configuration. And we've been looking for a surge force of paramedics in the south that will allow us to use our contract carriers and being able to transport 2 vented patients at a time in the SA carrier fleet. So we've been trying to prepare our fleet for augmented operations in the north. And we have one other plan for surge operations in the north, which is we've worked with Toronto Paramedic Services to configure their ambulance bus to allow for the transport of 8 stretcher patients or 4 vented patients at a time. This has been already done, and we're actually able to start ambulance bus operations in the south, say Collingwood to Toronto or so forth. What we want to do is extend this capability to the north. So we've put in a request both through the federal government and the provincial government to allow us access to a military transport plane, either a C-130 Hercules or a C-17 aircraft that would allow us to drive the ambulance bus onto the back of the aircraft, fly to the community in question, load them onto the bus, and then drive to a receiving center and drive to the hospital and offload the patients. This actually deals with a couple of different things at the same time. It allows us to surge paramedics from the south for a specific event in the north, and it allows us to transport from the airport to the hospital, which is often a bottleneck for delay. So it allows us to help with an immediate surge in a fairly novel way. So there's been a lot of good feedback about the proposal, but we're sort of waiting for it to make its way through the provincial government as a request to the federal government in an aid to the civil power type of scenario. So these are the things that Ornge has been doing to try to have some capability, an augmented capability to respond to surge in the north. Thank you.
Thanks so much for that, Dr. Tien. I want to say that I know that the chiefs of staff, when we spoke about this last week, found the creativity and capacity building that Ornge was doing really very reassuring. So I want to thank you for all of the work that you've done to enhance capacity and to help us to understand what the capacity issues and opportunities are for Ornge. So thank you, and thank you again for joining us today for this conversation. Again, if there are questions that come in through the chat box function, we will forward those to you and we will post your responses on the NOSM website. Thanks
very much, all.
Thank you. And with that, we will turn to Dr. Mike Scott. Again, Mike is an intensivist at Thunder Bay Regional Health Sciences and is the critical care lead for Ontario Health North, and has been really deeply focused on the ethical framework and surge capacity planning for critical care across Northern Ontario. Mike, I think you were able to see the video screen, and if you'd like the slides advanced, just signal as the need arises, and I'll turn it over to you.
Well, thank you very much. I just had a short presentation. Yeah, if you can put that up there, that would be great. It is, I go through two things. One is surge capacity, and the second part is the ethical triage piece, which is being developed and looked at through Ontario Health. So they kind of follow suit, seeing what this pandemic is obviously causing around the world. Next slide, please. To start off with, just talking about regional surge capacity planning. You can go to the next one as well. And generally, what we normally have at Thunder Bay Regional, just for everybody to know, is we have 22 beds, 13 ventilators run. There are different ventilators, for example, in the MRI, in the operating room, set up for transporting the emerge, et cetera, et cetera. To make a very, very long story short, our maximum surge capacity that we could handle for a few days using all operating room ventilators, all monitors, and all hospital spaces that have monitors would surge up to 81 beds with 41 ventilators. In addition, the Ontario Critical Care stockpile of ventilators, which is spread out throughout Ontario, but is set up so that in any region that there's a surge, that those ventilators can go, and there's no set number in any region. They are housed all around the province for ease of transport. It just happens that in Thunder Bay Regional, there are 7 additional stockpile ventilators in the basement. There's also an additional set of teaching type ventilators. They're the same as the Ornge transport ventilators, and they actually are housed at Ornge and with the EMAT team. There's about 25 of those across the province that Dr. Tien and Dr. Swadsky from Ornge have kind of kept under wraps. They're not fully maintenanced, but they work fine. But they're kind of kept under wraps as far as being used in the Northeast and Northwest. So that's, I don't know if Dr. Tien's too happy with me saying that, but I mean, it's something extra just in case for our northern regions. Next slide as well, please. In addition to those numbers, in Kenora, they have been able to find some ventilators and utilize space, and they can actually double their capacity as well. And they have found the ability to use 7 ventilators, including their operating room stock. If you look at all the other smaller hospitals across the province that are not captured in the critical care information system because they're not listed as having critical care units, there are approximately 13 ventilators across the rest of the hospitals in the region. Those ventilators, keeping patients in hospitals, using those ventilators is probably just about the same as transporting those patients to Thunder Bay Regional. And what we would do would be look at a full 24/7 support with our CCR and make the best decision as to transport. I think transport is going to be stretched, and there may be times when the hospitals need to keep patients on ventilators for a day or two just waiting for transport. So again, we have full support with our CCR, and we're looking at having a dedicated RCCR physician that can be online 24/7 in addition to our usual service. Next slide, please. So to sort of summarize, we're looking at a pandemic. We need a lot of resources. Our usual, as I said, is 13 ventilators that run for the region, basically, in Thunder Bay, and 1 or 2 in Kenora. We can extend ourselves and our staff and everything we got to a max of 61 ventilators. Plus, there's a stockpile of potential 32. So we're looking at like 90, which is ridiculous, and 101 monitored beds across the region. So this is, going from our usual to 400% of our usual. Very high acuity patients. It's a lot of capacity, and I'm hoping that's enough, but we don't know if it's enough. And if it's not enough, we move on to the next system, which is an ethical triage system during a pandemic. Now, the most important part of looking at this is really, when we see people coming in who need critical care, one of the most important things is to actually decide whether or not a person will benefit from it. You can put anybody on a ventilator and anybody on life support, but are they going to benefit from it by being able to recover and return to a reasonable state after their critical illness? And that is the question that really needs to be asked on presentation of people when they come in. This document that Ontario Health is putting together tries to address the question and have people ask the correct questions and use as many possible prediction models and scores as they could use in order to predict whether or not someone is going to recover from a critical illness or not. Next slide, please. This is what the cover page of the tool looks like, the Clinical Triage Protocol for Major Surge in COVID Pandemic. It has not been approved formally by Ontario Health and by the government, and it is not being implemented. However, everybody needs to read it just so they're familiar with what it entails. And if one day we need to have an advanced or a directive from the ministry to say you really need to start using this tool, then everybody at least knows what it is. It's not a huge document, but really needs to be read. Next slide, please. I'll go through the key elements of the document. Most importantly, their principles of utility, proportionality, and fairness. Is it going to be care with utility that's going to lead to recovery, or is it a futile level of care, which we have seen before? That's one of the big parts of it. Proportionality to all populations, and fairness to all parts of our population as well. We can go to the next slide as well. It's a document that was put together by some very, very smart people starting in 2003, and it's been built on continuously since then. The triage inclusion criteria that they note specifically for respiratory and for cardiovascular issues, these are the only two that they really put in. So refractory hypoxemia sat under 90 with an FiO2 mask of over 85% and a pH of less than 7.2, et cetera. So those are sort of guidelines as to when we look at intensive care. Next slide, please. In looking at the inclusion criteria, they put together this summary slide of kind of percent of normal capacity over time and what level triage criteria are going to be used in the middle of the slide. It is in the middle of the document. You can see on the far left of it, the normal sort of business as usual, going to minor surge. If it hits moderate surge, we'll start thinking about things. If it hits a major surge, there is a potential for the government to call for all hospitals to look at level 1 triage criteria, which generally is what most of us do at the present time. Is the person in front of you going to benefit from an intensive care stay? Are they going to recover from a critical illness? Or is this an illness that will eventually lead to the demise of the patient? Moving forward to level 2 and level 3 criteria gets a little bit more stringent and a little bit more difficult and deals with potential of withdrawal of life support in certain circumstances. As you can see, it's a very fluid graph and a fluid time period. The number of ventilators that are available and the amount of life support systems available will change on a minute-to-minute basis almost. And triage criteria may go up and down over that time. Next slide, please. One of the questions that's happened, especially in our region, is that there is a triage process within a hospital that involves at least 3 separate individuals or groups, which are the MRP, as well as a consulting physician from the critical care team. In smaller regions, that would be an RCCR physician or an internist, or even just a second physician who is in your hospital at the time. And a triage physician who may be a designated triage physician on a committee, or a consulting physician from the critical care team or rapid response team. So we're looking at 3 separate groups. The 4th group that is part of all this is a hospital triage committee. Now, there is only one bioethicist in all of Northwest. And we're making sure that there is some legal jargon in the document or attached to the document that will allow that one person to be an oversight of all hospital triage committees across our region. Northeast has exactly the same problem, as well as many places in the South. If you read it, it says the triage committee, which should at least include a physician, an ethicist, and a representative from hospital administration. Most people can find a physician and a hospital administrator, but an ethicist is quite a rare person to have in every hospital. So we're making sure that this wording gets changed, or that there is an addendum to allow our ethicist to participate in, or at least oversee all of the hospital triage committees. Next slide. There is an algorithm as to looking at criteria. There are inclusion criteria, as I showed you. There are also exclusion criteria that are quite specific within the document. And people should really read the document and make sure that they're familiar with it and familiar with the scoring systems and how to apply them. Some of them are quite technical and somewhat difficult. The bottom line is your clinical judgment is very important in having conversations with families and patients as to whether or not this type of critical care environment is the correct care for them. and whether or not there is a chance of getting through the critical illness, and whether or not there is an expectation that they will be able to recover. Again, clinical judgment, and we've all been in these situations, is probably the most important part. There are some extra criteria in here to help us if we get to 400% capacity of our normal. Next slide, please. There are, as I said, excluding criteria within the document. There are also allusions to special considerations such as pediatrics, neonatal, organ donation, and whether or not there are going to be organ donation possibilities. They all are alluded to within the document, and I think they require multiple special one-off conversations with multiple people. If we get to a point where we're triaging within the pediatric community, I think that's going to require a lot of people at the table discussing this on a case-by-case basis. Fortunately, it doesn't look like that's ever happening or there's any thoughts that it's going to happen, especially in this pandemic. So I think that's important to note. And the bottom line from this standpoint is when, it is business as usual, RCCR is there to help. Transport is probably going to be the sort of bottleneck rate limiting step of patients moving. We can, as a region, increase our critical care capacity to 400% of what it is now, which is a phenomenal number. But at the same time, we have to make sure that those resources are appropriately utilized, and that the early knowledge of the triage tool will definitely help to prognosticate patients and make sure that they are well taken care of appropriately. And I think next slide is to ask if there's any questions.
Thanks so much, Mike, for that overview of the triage tool. You've made reference to the importance of familiarizing ourselves with it. So I just wanted to start with a comment, and that is that the triage tool is available under the critical care resources section of the NOSM COVID-19 resources webpage, and that can be found under the CEPD link. So if you haven't already seen the triage tool document, you can find it there. We do have a few questions. The first, Mike, is about the surge capacity data for the Northeast. I think the data that you presented for the Northwest was terrific and really helpful to see. I'm wondering if we can pull in the Northeast data and post it on the NOSM website as well.
I can do that. I will forward that actually as soon as I finish answering questions. I do have that. Jose Theroux from Health Sciences North has put together a very detailed spreadsheet of every hospital's availability, and I'll see if I can find the summary sheet. I'm sure I have it here, and we'll send it off as quick as I can.
That's great. Thanks so much for that. I'm just going to check and see if Dr. Zaki Ahmed has been able to join us on the line as well. Zaki, if you can unmute and say hello.
Hello.
Hi, great. Thank you, Zaki, for joining us today. We've had the presentation from Dr. Tien and just now from Dr. Scott, and we're moving into questions. A couple of these questions I'll direct to you as a Chief of Staff. And the first one is about health human resources. So we've talked through Dr. Scott's presentation about the importance of ventilator capacity, but we know that we also need the people to monitor and manage all of those ventilators. And I wonder, Dr. Ahmed, if you can speak to the issues of RTs and ICU nurses and how we might staff the ventilator capacity that we anticipate we might have available.
Yeah, so I mean, I think as Mike Scott just alluded, we can go up to 60 vents or even more in Thunder Bay. So some of this is going to be where you start doing multitasking, where you're going to have teams made up, where you may not have the complete capacity if you use the highest capable people. However, if you were to build teams where you have one person who is able to run the vents and then other team members that can participate, that would be the model that we would have to look at if we get up to the 60.
Thanks so much for that. Dr. Scott, I'm going to go to you for the next question. So if you can unmute for that. It's really about the application of the triage tool. And if we are entering into the triage levels by region or as a province, and if we're entering into it as a province, might patients from Southern Ontario be flown to Thunder Bay if the ventilator capacity of Southern Ontario is reached and we still have capacity in Northern Ontario?
That's actually a very good question. It's being discussed continuously right now. I'm one of the members of the Ontario Critical Care Command Center for looking at capacity and potential patient movement, as well as equipment movement, et cetera. It meets every morning, gets a dashboard of what's happening. Excuse me, and continues to make suggestions around this. It appears right now that all centers are seeing small numbers of people affected at the same time. So provided that there isn't a zone of no activity versus a zone of high activity, it looks like things are coming up across the province uniformly. And in that case, resources are going to be proportionally stretched across the province. So we, as far as the triage tool goes, everybody is on board with implementing things from a province-wide standpoint. And there may be some movement of some patients, but the thought right now is that things are all going to happen at the same time. So there isn't going to be the ability, for example, for Thunder Bay to take 30 people from Sudbury or from Toronto. If there is that thought, it will be decided upon on a one-off basis at Command Center with multiple conversations going on an every 6-hour basis, pretty much.
Thanks so much for that, Dr. Scott. It sounds like it's really a dynamic process of assessment and evaluation of capacity day to day and hour to hour. So thank you for that response. Dr. Ahmed, I'm going to come back to you for the next question with your Chief of Staff hat on. If the surge plan includes using operating room ventilators, what's the plan for how we manage emergency surgeries in our hospitals?
Right. So we wouldn't. So right now we've gone from running 9 to 14 rooms down to 2 rooms that are functioning at the majority of the time, and then adding on a 3rd room for the cases that we have coming in emergently. So with that, we would continue doing those. So that would still leave us with 11 ventilators. So it's not as if we're going to remove all of them. We would have to continue dealing with the emergent surgeries, as someone's pointed out. We would just take out the ones that we're not currently using.
Thanks so much. And I anticipate that sort of applies across all of our sort of secondary and tertiary level hospitals across Northern Ontario as well.
That's exactly what everyone else is doing as well in their pandemic.
Great. Thank you. The next question, maybe I'll also ask of you, Dr. Ahmed, in terms of the ventilator surge bed capacity in the north, where are extra beds being allocated? And are we looking into utilizing hotels and community centers? I think this is really about how do we decant some of those acute care patients who may not need the fulsome critical care resources of an acute care hospital, but may need to be kept closer and under some degree of medical supervision.
Yes, so that's exactly what we're taking a look at right now with the Ontario Health Steering Committee that I sit on. One of the things is we're looking at is the expansion, and we have looked at a few places that we're expanding into. St. Joe's has been fantastic at trying to help us out, so we're trying to see what we can get into St. Joe's. We're looking at some of the local hotels. So those of you who are familiar with Thunder Bay, we're looking at the Days Inn that's just off our property. We're looking at the Creighton Center. So there's multiple places where we're looking. So there's opportunities for us to expand into those places.
Thanks
The
very
issue
much.
will be, the issue will be the health human resources. So I think what's going to happen is you can expand in terms of spaces. What's going to happen is, as you are very well aware, more than physician is going to be the nurses. That's going to be the challenge.
Yeah, thanks very much for that. The staffing is going to be an issue all across the north. And one of the things that comes up in that way is really links to the next question, which is the degree to which small sites will be expected to manage patients on ventilators. And I'll go to you, Dr. Scott, for this question. You had mentioned in your presentation that with transportation being one of the rate limiting steps, that we might anticipate that people will be in our settings for perhaps a day, maybe a bit longer. Can you speak to what the expected response of small communities is to maintaining people on ventilators for more than that window of time that we're waiting for transfer? Is that something that's factored in to the capacity plan, or is the expectation truly stabilize and transfer without expectation of long-term ventilation on site in small places?
I think if we got past our 400% increase within Thunder Bay Regional, or even getting close to that, I think we will lose nursing resources at an alarming rate, be it from sickness, burnout, et cetera. It really is a dynamic question again. At the present time, there is no expectation that any of the smaller hospitals will have to keep patients for prolonged periods of time. But again, if there are absolutely no resources available, then it's always a possibility, but it is a sort of end of the line possibility. And we're hoping we don't get there.
Thanks for that. I'm going to ask a corollary question, and I'll keep this question with you, Dr. Scott, but I think as we anticipate sort of that 4 times our usual capacity in ventilator utilization in the bigger centers across Northern Ontario, and the resource, that precious human resource that is our intensivist group. When I think about the support that our CCR and virtual critical care in the Northwest and Northeast respectively have provided to small settings, I'm wondering if you're anticipating that our CCR will actually be able to be available to small settings in the way that it has in recent years, if that human resource is stretched so thin with managing patients on ventilators in our tertiary settings.
Yes. Interestingly, we have some intensivists who are not or do not reside in Thunder Bay, reside outside of Thunder Bay for the most part. Those physicians are not necessarily able to travel at the present time and have been working in hospitals with COVID positive patients at times. So our plan from that standpoint is to utilize those physicians as 24/7 RCCR physicians, as well as our intensivists who are not fully on service during the week. So we're hoping to have a dedicated RCCR physician, as well as increase the staff of Thunder Bay Regionals to a second on-call person at night. So we're looking at increasing our intensivist work model, which hopefully doesn't become too difficult on the existing intensivists who are in town.
Thanks so much for that. I think that's really reassuring for those of us who have relied on our CCR for the terrific support you've been able to provide over the last several years. I'm going to go to the next question, which is maybe more of a comment, and there have been a couple of comments in a similar vein. But the question is, will people from Fort Frances, as one example, be stabilized and then transported to Thunder Bay? Being away from family at a time of 50% mortality risk likely may mean that some people choose comfort care only. And there was a previous comment about one of the things that drew the commenter into family medicine was really the rich opportunities for conversations about values and beliefs and goals of care, and the opportunity that this emerging crisis presents for us to be entering into those conversations with our patients and supporting them to be clearer about what it is that they want, and to be clearer about how they might understand the implications of having a severe COVID-19 illness. I know there are a couple of resources in the back of the triage document, but I wonder, Dr. Scott, if you might speak to that sort of approach to acute palliation of the critically ill COVID-19 patient and supports that may be available for those conversations.
There actually is some scripting at the back of the triage document, which is very useful. I think one of the things that we all have to ensure we realize is that not all patients presenting looking like they are COVID until we get very rapid testing. They may also have other mimicking diseases. I guess the triage tool or the discussions that take place with families and patients should be based on how severely ill the patient is at the present time. If there is a comorbidity or a number of comorbidities that exist with it, as well as the frailty scores and other diagnoses that are available. Using for many patients that come in, looking at their critical illness and what their numbers are, what they look like, et cetera, using our clinical judgment, we can generally discuss whether or not life support systems are going to be appropriate or useful in the situation. And I think we try and continue as close as possible to that. I guess at the far end of the spectrum, if you're looking at level 3 triage, where we actually have to actively withdraw in patients, I'm scared that may have to happen. But again, there are a lot of tools and there's a lot of scripting that is in the document that should help most physicians with this.
Thanks very much for that, Dr. Scott. And I think that there is some emerging information from the palliative community as well about how we enter into those conversations. And James Gertzen and I were having a conversation earlier about including some of those palliative care links on the NOSM site as well. So just encourage everyone who's participating in the webinar today to stay tuned for that and to look to the NOSM site for those resources in the next day or so.
Yeah, I think that's going to be very, very important.
Yeah, and I think it's one of the things that's really very top of mind for family physicians as we enter into this time with our patients and our population. Dr. Ahmed, I'm going to go to you for the next question. This is certainly something that's concerning everyone from primary care through to intensive care units. But I wonder if you could comment on the ways in which the shortage of personal protective equipment is currently being mitigated in Northern Ontario specifically.
So, I mean, I don't think it's just unique to Northwestern Ontario. It's a worldwide issue at this point, where our supplies are extremely limited. Right now, we've just started, or we're just starting to recollect the N95 masks for recirculation. I'm sure most of you have gone through literature where they're trying to use either hydrogen peroxide, UV, autoclaving. So there's all these different techniques. So we're starting to recollect our N95s to try to recirculate that. The biggest barrier right now that we're facing is surgical masks, which are the ones that you're supposed to use for most of the contact that you're going to have. So those are the ones that are in extreme shortage. We are running, because that's very easily available. People are buying that everywhere. That's the one that right now, if we were to use what we have in Thunder Bay, we would, at the current rate, we would be out of it very, very quickly. So we're trying to, first of all, allow for the proper usage and the right times. And then secondly, try to see if we can allot how we give them out rather than just free for all.
Thanks very much for that. This is certainly a really challenging issue all across the healthcare system. So thank you for that response. Dr. Scott, I'm going to go back to you for two, I think, fairly straightforward questions. The first is, how long does the average COVID patient require a ventilator for?
It is variable, but the most ill, I think they're saying 11 to 14 days of ventilation before being able to be extubated. Is that the last set of data that you saw, Dr. Ahmed?
Correct.
Thanks very much for that. The next, again, I think is a fairly straightforward question, but you made reference in your presentation to the frailty scores. And I wonder if you could speak to what that frailty score is specifically and where people can find it.
It is actually in the OHT document. There are some, I don't have it sitting right in front of me, but I will look it up. It basically goes
Ahmed, Mike, if you want me to take this.
Yeah, thanks. That would be perfect. I haven't got it sitting right in front of me.
So it's actually right in the Appendix A of the clinical triage protocol for major surge. So it's on page 10 of the document. It goes through, it's a very easy score to use. So I know I've had some questions from people like cardiologists on the core health committee that I've sit on in terms of how do I need to get a geriatrician to do this? So the answer is no. It's a very easily clinical frailty score, 1 for very fit, 2 for well, 3 for managing well, 4 for vulnerable, 5 for mildly frail, 6 for mildly frail, moderately frail, and it goes on to what moderately frail is. In the protocol, it actually gives you different criteria. If you're less than or equal to 3, that the only time we're going to take a look at that is if you're in stage level 3 surge, and less than 5 or equal to 5 would be in a level 2 surge, and level 1 surge would be less than 8. So you'd have to be very severely frail, which is completely dependent, approaching the end of life. Typically, they could never recover from a minor illness. Those are the ones that we would take out in level 1 surge. Does that answer your question?
I think that's really helpful. Yeah, thank you for that. And again, people can find that reference. There's a good infographic with some images and some brief narrative in the triage tool document. So really encourage you to have a look at that on the NOSM website. Dr. Ahmed, I'm going to go to you for the next question. There's a little bit of narrative context to this. So CBC released that the college, the CPSO, will grant temporary licenses to IMGs from other countries. I know we have numerous physicians in community who are not able to obtain residency spots or register with the college who are now working in non-medical roles. Would Thunder Bay, and perhaps I'll ask by extension for all of Northern Ontario, look at allowing them to work in our hospital if they were to get the license, should we need more?
Yeah, so that's an interesting question. So what we have looked at right now is we're looking at expanding our services. So luckily, we are lucky enough that there are surgeons who are not able to do essential or non-essential surgeries at the moment. There are other specialists like gastroenterologists and others who are not able to do their usual work that they would have in these times. So we've been fairly lucky that we haven't had to go to that. Although we have taken a look at the CPSO guidelines, and even for retired physicians, and I'll go to the IMG. I know that's the question was specifically for IMG, but even for retired physicians, if it's more than 2 years that they've been retired for, they have to do a full new application, which is not the expedited way. The expedited way is only for physicians that have retired in the last 2 years. For IMGs, it's still the same mechanism that they would go through. They wouldn't have to go through the licensing exams. They have laxed some of those. So I think in areas where, especially in the rural areas where there's going to be a need long term, that may be something to take a look at, especially if you know of someone who's in that situation. I think it would be a very good option to go to.
Thanks so much for that. And I know that the CPSO has certainly decreased their requirements of strict supervision in order to enable some of the IMGs in our region and really across all of the province to be able to have some support, but with a decrease in the quite constraining rules of supervision that have historically existed. So I think that's a really important point to raise. Thank you for that.
And they've gone to a supervision from a remote site as well for the IMGs, which is a different and allows you for a lot more flexibility.
Absolutely, yeah. So terrific for people who are in any of our communities across Northern Ontario to think about whether they have the capacity to support that kind of IMG supervision, even remotely in support of another colleague in a different community. And I think Health Force Ontario has reached out to each of our communities through each of the chiefs of staffs or CEOs to seek some understanding of whether communities have the capacity to do that. So that's terrific. Another question, this is really around sort of parallel to the personal protective equipment shortage, but certainly we're hearing more and more about shortages of critical drugs. And I know locally here we're looking at the volume of rocuronium and identifying that we really only have enough locally currently for 3 inductions and several hours of paralysis for intubated patients. And that supply chain for some of those critical care drugs seems also to be disrupted at this time. And I'm wondering if you can speak, maybe I'll go to you first, Dr. Ahmed, and then to Dr. Scott from a broad regional OH North perspective. But I wonder if you could speak to the shortage of critical care drugs.
Yeah, so absolutely. There is a shortage of a lot of drugs that you mentioned, cystatin, rocuronium. So people have moved away from cystatin to get to rocuronium because that was short. Now that rocuronium is short, we are going to run into a point where we're going to be short of sedating medications and salbutamol, which is a big shortage that's around. Luckily, I think as we're getting more and more data, and I think Dr. Scott's going to agree with me, is we're learning that actually paralysis may not be the right thing for these patients in critical care. So what you're going to see is a lot of us are going to be managing these patients that were unlike the typical ARDS patient, where we're going to allow them to have permissive hypoxia, which is something that we would never allow anyone to do. There's going to be times, and they're shown to be of benefit. So there's going to be times where we're going to be using ventilatory modes that are more compatible with non-paralyzed patients. And those are the different techniques that we are already starting to adopt, and not just us, everywhere in the world as more and more data is coming out. And hopefully that'll address some of it. Won't address all of it. And right now, Health Canada is working on trying to get us those medications. But as you said, it's the supply chain that's the issue.
Thanks very much for that, Dr. Ahmed. So I'm mindful of time. I think we'll go to Dr. Scott just to comment on any additional medication-related issues. Then we'll go back to Dr. Gertson for the last question and then a wrap up. So Dr. Scott, over to you.
Yeah, I have no other comments other than what Dr. Ahmed said. The landscape of what we're learning about how patients respond to different therapies is happening on a daily basis, and we're fortunate in this day of information sharing to be able to pick up on that pretty quickly and be up on the latest latest treatments and observational treatments, as well as some trials going on at the present time as well.
Thanks so much for that. I'll look to you, James, then for the next question. We'll have a last answer and then back to you to close on the webinar for today. Over to you.
Thanks so much, Sarah. Really, I think it's a question for you in your role as a primary care physician, Dr. Ahmed in his role as a critical care specialist, and also Dr. Scott. We're all going to be having lots of advanced care discussions. What's the appropriate role to involve NOSM learners, students and residents in those discussions?
So maybe I can address that first from a primary care perspective and then pass it over. I mean, I think these are conversations that are really important conversations. I think they're important to role model well for our learners. I think it's important to invite our learners into those conversations as much as we are able to do that. And I think certainly from a primary care perspective, it is not uncommon to need to role model the way in which we engage in conversations with our patients when we are uncertain about things. Certainly primary care is a space that uncertainty is kind of the foundation of the work that we do, and being able to have conversations that are as honest and as candid as we can, even though we don't have the full picture, but we can focus on patients' values and their goals of care and what we know of them and the community context in which they live and we live together. I think there's a really rich opportunity in that, and a rich opportunity for learning for our medical students and residents. And I know medical students are not involved in our clinical space currently, but for now, for our residents, I think there's a really important opportunity. I'll turn it to Dr. Scott. You might be muted.
Sorry about that. Yes, I was. I think that involving the residents in those discussions is very important. I think more importantly, it's in looking at the criteria of who would generally benefit from critical care. Having the residents evaluate based on those criteria what their thoughts are. And I think if we have good, experienced clinicians allow the residents to take part in the conversations, I think that that will make them much better clinicians in the long run. If we're getting into triage territory, I don't know if residents should be tasked with the responsibilities that are involved with that, but I think learning from this would be very important.
Dr. Ahmed, I don't know if you have anything you'd like to add to that.
Yeah, if there is a minute, I would like to ask.
Sorry, Dr. Ahmed, we didn't quite hear you.
Yeah, I would like to ask a question if there is.
Yeah, I'm sorry, we can't take questions because we'll be winding up. We're just asking for Dr. Ahmed to answer the question, please. Dr. Ahmed.
We may have lost him from the call, Dr. Gertz, and I saw his video disappear. Just to Dr. Kodalik, if you'd like to submit your question, we can seek an answer for you that we can share on the NOSM resources. So I hope that you'll send the question in, despite the fact that we can't answer it now. James, over to you, James.
As mentioned, you can certainly push your questions via WebEx, and we will still capture those in the next 5, 10, 15 minutes. Also, our CPD website is also an opportunity. We really are looking for information and your feedback on how we can improve our rounds. When you came in on your WebEx link, there is a little button that says April 3rd evaluation. Please fill that out, and also we're quite happy to record your attendance so that at some time in the future we'll be able to issue certificates for every session that you attend. So please take 1 or 2 minutes as we wind up today to go back to the website where you registered, click the button, answer a few questions, give us your name, and we'll make a record and forward study credits to you in the future. Next Friday is Good Friday, and we will not be broadcasting. Hoping many of you and all of you can join us on April 17th when Dr. Curtis Addison. Curtis is a NOSM internal medicine graduate who's presently a fellow at University of Western Ontario, planning to return to the North. So Curtis, together with Barubi Beeman, will be looking at issues around respiratory care in Northern Ontario amidst the pandemic. I'd like to thank all of our presenters, our moderator, Dr. Newberry, our 2 presenters, our 3 presenters, Dr. Scott, Dr. Ahmed, and Homer Tien, who had to leave early. Back to you, Sarah.
Thanks so much, James. I just really echo my gratitude to the group that has provided leadership around our critical care capacity and transportation capacity across the whole of the North. This is a very challenging space for all of us, and your leadership and your wise guidance in this, I think, is really very reassuring and helpful. So thank you for that. Thanks to everyone for submitting your questions today. We'll look forward to any future questions that you have, and again, to getting those resources out to you. We really want to support all of the clinicians across Northern Ontario in this really critical work that you're doing to support your patients and your communities and to provide the best care that you can for all of the patients who need you. So thank you for being here today and for participating in this session.
Thanks, Sarah. And as we are saying to each other on a regular basis, please take care of yourself. Please take care of your family. Please take care of your colleagues. See you in 2 weeks. Have a great day.
Thanks, James.